One is the anatomy and its implications, anatomy of larynx and its implications on anesthesia. Another one included is the pH, importance of pH and its functions, why it is to be learned well, especially by anesthetists. And of course, there is a case scenario on chronic obstructive airway diseases, patient coming for laparoscopic surgery. And if time permits, we will complete some of the last questions that we saw last week. And so who is going to present first?
So me, sir.
You are presenting
Anatomy and larynx and anesthetic
anatomy of larynx and its implications. Okay, very good. Go
ahead. Laryngeal anatomy. Larynx is a segment of respiratory tract which is present in the anterior aspect of neck. It is about 5 centimeter in length and width. It is slightly short. It has slightly shorter antero-posterior diameter. It is located in C4 to C7 vertebra, which is held in position by muscles and ligaments. Superiorly, it is formed by epiglottis, which is attached to hyoid bone, which is connected to inferior part of the pharynx. Inferiorly, it is connected to superior region of trachea. And the functions of larynx, it acts as a protective sphincter for respiratory tract, which separates the trachea from upper GI tract. It prevents aspiration during swallowing, and it contains vocal apparatus, which is effective for communication, and it is useful to perform an effective cough and Valsalva maneuver. And laryngeal skeleton is made up of 9 cartilages, which is 3 unpaired and 3 paired cartilages. The 3 unpaired cartilages are thyroid cartilage, cricoid cartilage, and epiglottis. 3 paired cartilages are arytenoid, cornicate, and cuneiform cartilages. The larynx is divided into 3 parts, which is supraglottis, glottis, and subglottis. Now, regarding supraglottis, which connects the larynx to the base of the tongue, which extends up to the ventricle. The subdivisions of supraglottis are epiglottis, array epiglottic fold, which is connected from arytenoid to epiglottis, arytenoids, false vocal cords, and ventricle. And the mucosal lining of supraglottis is made up of stratified squamous epithelium. And the supraglottis is rich in lymphatics, and it exits through thyroid membrane to form jugulo-digastric nodes. The clinical significance of this is cervical metastasis is most common in this side. And epiglottis, which is a leaf-shaped, which is made up of fibrocartilage, and it has a narrow base, which is pedicle, which is attached to the thyroid cartilage. And epiglottis is made up of 2 surfaces, which is laryngeal surface and lingular surface. And the lingular surface is connected to the vallicula by the glossoepiglottic ligament. And it has 2 parts, which is suprahyoid epiglottis and infrahyoid epiglottis. The suprahyoid epiglottis has a free end, and the infrahyoid epiglottis is divided into numerous pits, and it is related to pre-epiglottic space. And in cancer, early pre-epiglottic space invasion is most common. And array epiglottic folds, which extends from arytenoid to epiglottis. It contains cornicate and cuneiform cartilages. And array epiglottic folds, false vocal cords, and true vocal cords. All these 3 form sphincters during pharyngeal phase of the swallowing, and which is important for swallowing reflex. And if the array epiglottic fold is flabby, there is a condition called laryngomalacia. And regarding the glottis, it has 3 parts: true vocal anterior and posterior commissure. And there is a term called rima glottis, which is a triangular space between the 2 true vocal cords. It extends up to 1 centimeter below the free margin of the vocal cord, and it is the most narrowest portion in the adult larynx. And Regarding the vocal cords, it is made up of anterior two-thirds and posterior one-third. And the anterior two-third is membranous, which is formed by the vocal ligament and muscle, and posterior one-third is fibrous, which is formed by the vocal process of thyroid. And the vocal cord inserts into the midline of thyroid cartilage via the Broyles ligament, which limits the inferior spread of the glottic cancer. This is the clinical applied aspects. And at the level of insertion of vocal cord, inner perichondrium is absent. And regarding the anterior commissure, it is the area between two vocal cords. And in males, it is formed by midline between the thyroid notch and the lower border. And in females, it is formed by the junction between upper one-third and the lower two-thirds. And regarding the applied aspects, anterior commissure webbing is most common. And in posterior commissure, it is the area between vocal process, which is the respiratory portion, and posterior commissure scarring mimics bilateral abductor cord palsy, which is the clinical applied aspect. And in subglottis, it extends up to the lower border of cricoid cartilage, which has two parts, which is a mobile upper part and a fixed lower part. And the mobile upper part, it extends below the vocal process to the upper border of cricoid cartilage, and the fixed lower part extends up to the inferior border of cricoid cartilage. And regarding the differences between adult and pediatric larynx, in adult, the narrowest portion is the vocal cord, and in the pediatric, the narrowest portion is the subglottis. In pediatric, epiglottis is floppy and omega shaped, and in adult, it's firm and flatter. And clinical significance is that subglottic stenosis is most common in pediatric airway due to the non-expansile ring. If it is present, the lower half will be treated by resection and anastomosis, and upper half of the stenosis is difficult to treat since arytenoid limits the resection. And the thyroid cartilage, which is a two, which has a two lamina which fuse in the midline to form the thyroid prominence, and in males it is acute angle 90 degree, and in females it has an obtuse angle which is 120 degree. Cricoid cartilage, which is a signet ring shape, and it has two parts, which has an anterior arch, which is 5 to 7 millimeter, and posterior lamina, which is 2 to 3 millimeter. And regarding the clinical aspects, cricothyroid joint, which is related to the recurrent laryngeal nerve, and arytenoid cartilage. Arytenoid cartilage has three processes, which is apical process, muscular process, and vocal process. And clinical significance is that it is most commonly injured by protrusion of an ET tube, endotracheal stylet, or traumatic intubation due to unanticipated difficult airway or prolonged intubation, and using of a bougie or blind intubation techniques, or insertion of a development tubes, or other history of chronic corticosteroid use, laryngomalacia, acromegaly, and use of transthoracic esophageal echocardiography also causes arytenoid injury. And elevated BMI is also an independent risk factor for the injury of the cartilage. And the patient with hoarseness of voice and difficulty in swallowing and pain in the anterior region. And regarding cornicate and cuneiform cartilages, these both are vestigial structures within the array epiglottic fold. It is used for resonating the larynx after vertical emphysectomy. And the muscles of larynx are extrinsic and intrinsic muscles. The extrinsic muscles are further divided into suprahyoid muscles and infrahyoid muscles. The suprahyoid muscles are stylohyoid, genohyoid, mylohyoid, thyrohyoid, stylopharyngeal, and digastric muscles, the main function of which is to elevate the larynx. And the infrahyoid muscles are omohyoid, sternohyoid, thyroid. The main function is to depress or lower the larynx. And intrinsic muscles are divided into the pad and unpaired muscles. The unpaired muscles are the arytenoids, which control the true vocal cords. And the functions is to coordinate the phonation, respiration, and sphincter mechanism, and for cough reflex. And no supply of larynx, all intrinsic muscles are supplied by the recurrent laryngeal nerve, except for cricothyroid, which is supplied by the external branch of superior laryngeal nerve. And the cricothyroid muscle is the only exception in this. It is the tensor of true vocal cord, and cricothyroid muscle is originated from the cricoid arch, and it is inserted into the inferior border of thyroid cartilage. Its main action is to make the vocal cord thinner and longer, and so that increase in pitch of voice is obtained. And and the action and the other muscles of action are there are two actions obtained: abduction and adduction. The main abductor of vocal cord is posterior cricoarytenoid, which is supplied by recurrent laryngeal nerve. And the other adductors of vocal cord are cricothyroid, lateral cricoarytenoid, interarytenoid, and the external part of thyroarytenoid. All are supplied by recurrent laryngeal nerve except the cricothyroid. And the tensor of true vocal cords are two muscles, which are cricothyroid and the internal part of thyroarytenoid, otherwise known as the vocalis muscle. And clinical aspects in recurrent laryngeal nerve palsy, the cord assumes the median or paramedian position due to cricothyroid overactivity, and the intensity of voice is related to the expiratory effort of subjective pressure. And the origin of superior laryngeal nerve. The superior laryngeal nerve separates from the vagus just outside the jugular foramen at the inferior vagal ganglion. And at the level of the hyoid, it divides into internal and external branches. The internal branch further passes through the thyroid membrane and provides sensory innervation up to the vocal cord. The main clinical aspect is that the superior laryngeal nerve branch can be blocked outside by injecting the local anesthetic drug through the thyroid membrane. And the external branch supplies the cricothyroid muscle. Recurrent laryngeal nerve. The recurrent laryngeal nerve branches from vagus in thorax and loops around arch of aorta in left and subclavian artery on right before traveling back up between the esophagus and trachea, which supplies all the intrinsic muscles of larynx except the cricothyroid and the sensation to the larynx below the true vocal cord. And the clinical aspects of this is Ortner's syndrome, which is hoarseness of voice due to left recurrent laryngeal nerve palsy caused by mechanical compression of recurrent laryngeal nerve from enlarged left atrium in mitral stenosis. Theories on vocal cord paralysis. There is a law, two laws known: Simmons law, which is in progressive lesion of recurrent laryngeal nerve, the abductors are paralyzed before the adductors. In an incomplete paralysis, the cord will be brought to the midline by the adductors, but in a complete paralysis, it falls away to the paramedian position. If it is unilateral damage, unilateral cord will partially compensate. And there is another theory known as Wagner-Rossmann hypothesis, which is also widely accepted, where in complete paralysis of recurrent laryngeal nerve, the vocal cord will be in the paramedian position, but because of an intact cricothyroid muscle, which adducts the vocal cord, when superior laryngeal nerve also paralyzed along with recurrent laryngeal nerve, then the vocal cord will assume an intermediate or cadaveric position since there is a loss of adductive force. And apply to the larynx, it is derived from it is derived from external carotid arteries which further divides into superior and inferior thyroid arteries, which further divides into superior and inferior laryngeal arteries, and also by the subclavian artery, which supplies the larynx. And venous drainage is formed by the superior laryngeal vein and the middle thyroid vein. And lymphatic drainage is formed by above the vocal cords, it is by upper deep cervical nodes, and below the vocal cords is by the lower deep cervical nodes. And the vocal folds as such has no lymphatic drainage. And the clinical aspect is that regarding a cricothyroidectomy, which is an opening made by making a slit in anteriorly in the relatively avascular cricothyroid membrane, and others ligaments and membranes formed in larynx are thyroid membrane, ioepiglottic ligament, cricothyroid membrane, and cricotracheal ligament, and cricovocal membrane. And the cricovocal membrane, which is formed by upper border of cricoid cartilage to the laryngeal prominence of thyroid cartilage and vocal process of arytenoid, where the upper border forms the vocal ligament, which provides structure to the true vocal cord. And other applied anatomy is local anesthesia for airway is essential for awake fiber optic intubation, where we use mostly topical lignocaine, and other blocks can be done superior laryngeal nerve blocks and transtracheal blocks. Laryngeal nerves most commonly injured by the causes are surgery, most commonly due to thyroid surgery. Other causes are carotid artery surgery, lung surgery, and cardiac surgery. And it is also injured by lung, esophageal cancer, or enlarged lymph nodes, or due to enlarged right atrium, or there is a cervical trauma, or laryngeal nerves can also be injured by insertion of an laryngeal mask airway or endotracheal tube intubation. Superior laryngeal nerve, which is external branch is damaged during the thyroid surgery as it lies along with the superior thyroid vessels. Other applied is the recurrent laryngeal nerve, which is damaged during thyroid surgery since it lies close to inferior thyroid vessels. Due to long thoracic course of the nerve, it is also damaged by aortic aneurysms also and enlarged lymph nodes also. Unilateral recurrent laryngeal nerve injury, where the vocal cord assumes a midline position, patient presents with hoarseness of voice and ineffective cough and recurrent aspiration. And in case of bilateral recurrent laryngeal nerve palsy, the vocal cord function will be lost and it leads to life-threatening airway obstructions. And other uses are in emergency airways where the can't intubate, can't ventilate situations. The methods used are needle cricothyroidectomy and surgical cricothyroidectomy, which is known as Melker's technique, and also percutaneous Seldinger's technique of tracheostomy is followed. Thank you, sir.
Very good. That's a very, very elaborate and very nicely classified answer. But of course, a few points are missing in that. Don't you think you should write something about laryngospasm when you talk about anatomy of larynx?
Yes, sir.
Have you come across any case of
Yes, sir.
laryngospasm in your training period so far?
Yes,
Which group of patient is very common?
Pediatric groups.
Pediatric, very good.
yes.
Why pediatric
Pediatric.
patients develop this? What is the mechanism of this laryngospasm?
Reactive airways.
Reactive airways.
So what exactly happens in laryngospasm? Which part of the larynx is affected?
Glottis.
Glottis.
So the vocal cords go into adduction.
Adducted position. Yes, sir.
Adduction overtakes the abduction. So the glottis goes into adduction. What are the types of laryngospasm? It can be partial or complete. Okay.
Mm.
So in partial, what will happen? In complete, what is the difference between these two conditions? When you say partial, does it mean that the vocal cords are so tightly adducted that no air can enter?
No, sir.
No. So there is some opening, but
Some
the
space.
opening is so narrow that the airflow is very much restricted. The resistance will be more, isn't it? But some air is still going in. The child is breathing or the patient is breathing. But when it goes through a narrow passage, the airflow, what will it cause? Will it be going in silently or will it make a noise?
It will make a noise,
It
sir.
will make a
What
noise.
is that noise called?
Striders.
Strider.
Right.
So that strider is a very important component or physical, systemic manifestation of adducted vocal, partially adducted vocal cord through which air flows with a turbulence producing a noise. Okay. And the other condition is complete where the adduction is so close that you don't hear any air entry when you auscultate the chest and you don't get any stridorous noise also. Okay, then it is becoming, which condition is more serious, partial or total?
Total, sir.
Total is very serious.
Serious.
Okay. So in a pediatric patient, if there is a total or complete laryngospasm, what will happen to the child?
Rapid
If you don't interfere and
desaturation.
do something immediately, it's a very, very crucial emergent situation. So if the vocal cord spasm or adduction is not relieved sooner, what will happen? There is no airflow at all. So what will happen to the child?
Rapid desaturation hypoxia.
Rapid desaturation because no air is going in, no will. As long as the FRC is there, some oxygen will be available to the body from the functional residual capacity of the lung. Once that is exhausted, the patient will desaturate rapidly. In a pediatric patient, the desaturation, what will be the effect on the cardiovascular system?
Bradycardia.
Bradycardia and cardiac arrest. Okay? So children usually go into severe bradycardia if there is hypoxemia. Okay? So unless you correct the hypoxemia rapidly by opening up the conducted vocal cords and pumping air or oxygen, the child will rapidly develop a bradycardia and even cardiac arrest can happen. Okay? So once the cardiac arrest happens, then at the time the vocal cord will automatically separate because the respiration also has become paralyzed, right? But if you do and wait until the time, it is very, very risky. Sometimes you may not be able to revive the patient at all. Okay? So this is a very important complication that you have to remember. But otherwise, any importance about the histology of the vocal folds or the true vocal cords? Are the components of the true vocal cords histologically? Does it have any bearing? Okay, we will see that also. Now you talk so much about hyoid bone in your description, isn't it? Lot of structures are getting attached to the hyoid bone. Why hyoid is not included in the anatomy of larynx? We talk about only paired and unpaired cartilages. But hyoid is very close to the larynx, but still anatomists have not included hyoid in the anatomy of larynx. You tell me why that is there. So, have you ever thought about it? Idea? Okay, right. So we'll see the answers for that. Again, I want to congratulate Dr. Ranjani for nice preparation she has made. And I will just show